Hello, everyone. Thank you very much for joining us today for the THETA Round series. And today I'm personally very excited to be introducing this particular researcher and today's presenter, primarily because he's a real innovator in healthcare information systems and digital health technologies. And I think that we're going to get a lot of really interesting ideas and understanding of what's coming down the pipe in terms of how machine learning, stats, and a number of other key items that he's working on will be able to shape research and how we conduct ourselves going forward as a research community. So some background on Dr. Manlhiot is that he's the director of the Cardiovascular Data Management Center at the University of Toronto, which is dedicated to extracting new knowledge from clinical and scientific activities through enlightened data integration and use of data analytics approaches. Dr. Manlhiot is an expert in the development, implementation, and evaluation of novel data integration technology and analytics methods in healthcare. He is an affiliated scientist in experimental therapeutics at the Toronto General Hospital Research Institutes and the Cardiac Monk Center the Cardiac Monk Cardiac Center, Peter Monk, Cardiac Center, and associated scientist in the Sick Kids Research Institute and associate professor in the Ted Rogers Center for Heart Research, Computational Biomedicine program, which he also co-leads with Dr. Heather Ross. The aim of this program is to develop and implement new analytics methods based on modern statistics and machine learning to be used in highly complex medicine situations to generate patient-level predictions. And also, you may be aware that this is my first time hosting this event, and so I apologize for being a little nervous. But without further ado, please, if we could. Oh, actually, I forgot. There is one more thing before we welcome you to the podium. We also like to go around the room and actually introduce all of ourselves to you as well, Cedric. So to start, I'll like to introduce today's online moderator for the talk.
Hi, I'm Joanna Bilecki. I'm a research librarian here, and as Wilson said, I'll be moderating online webinar where we have 9 people online.
Hi, I'm George Thomas. I'm a biostatistician here.
Hi, I'm a PhD student. I'm Manuel Young. I'm a health economist.
Stephen Mack. I'm a PhD student at THETA.
Eric Wilson, I'm a PhD student about.
I'm Lucas Luda. I'm a research fellow at the Cedric Manlhiot Center with Dr. Ferkel.
Hi, I'm Leah. I'm from Marshall University.
I'm Biomedicine, a PhD student from THETA.
I'm Laura. I'm just starting my master's in health services research.
I'm Kate Westcott. I'm the program coordinator of the CBDMC working under Dr. Manlhiot. I'm HP. I'm a research coordinator at SICKIT. I'm Kate, project manager at SICKIT.
David, I'm a research assistant at SICKIT.
I'm Anna. I'm a biostatistician at SICKIT.
I'm a computer science student.
Rafael, research associate here at THETA.
I'm Leticia. I'm a PhD distinction.
Rafael, I'm a postdoc at THETA.
I'm Julia. I'm a biostatistician at the BRU.
Frank Cron, I'm director of THETA.
Troy Francis, associate here.
Stephen Carconi, I'm a research associate at THETA.
Fiona Sander. I'm a scientist here at THETA.
I'm Howie. I'm a director of Open Labs with the Computational group and published a paper on using predictive analytics with family practice electronic medical records.
And I'm Luciana Breman. I'm assistant professor at EOC.
Okay, fantastic. Well, thank you everyone for introducing yourself to Cedric. And Cedric, if you could take it away.
Yeah. Well, thank you very much for having me today. I'm very excited about presenting what we're up to all of you. So today we're going to talk about this slide particularly, The future is digital, the future is personalized. This is the tagline of the PMCC Phase 4 project, and is the tagline of about 20 different hospitals across North America. Everybody is jumping on that bandwagon right now. And what we're going to talk today about is about what we need to do to make this a reality. When we're talking about the future is personalized and future is digital, we're really talking about four things. We're talking about creating infrastructure to individualize patient care by enabling data-driven clinical care and patient management to the care continuum, increasing the speed of clinical research through seamless migration of data from clinical systems to databases, improve decision support by providing real-time monitoring of key quality and performance indicators, and finally enable transformative research by using big data and utilizing new analytics paradigm for computational statistics and artificial intelligence. It also means that we are going to need to move the medicine from generic medicine, which is the current standard where everybody is treated the same and does not require predictive analytics, to stratified medicine where management is performed by subgroup, which require moderately accurate probabilistic model, and it is currently possible only in situations where stratification can be accomplished on a few risk factors, to individualized medicine, where the management is truly targeted to the individual. And this will require a highly accurate predictive model, and today remains virtually impossible. The grand goal of truly individualized medicine right now, with the exceptions of a few areas in cancer research, are still a complete pipe dream. But what this actually really means is that we are going to need to start learning to embrace complex systems. Most biological systems are complex systems. That means two things. It means first that their behavior is rarely dictated by a small number of features, and they often behave differently than the sum of their parts. Now think of that against the classic approach for biomedical research, which is reductionist in nature. And the approach that we're using is completely antithetical to the study of complex systems. Generating insight from medical data will require embracing complex systems. That means big data, new analytics method, and real-time data, clinical data integration. Now there's three challenges here. First one is that the hospital IT infrastructure can't handle that much data. Second one is that our current methods of creating predictive model in medicine are not sufficiently performant. And the third challenge is that there's very little research on how physicians understand, integrate, and use clinical predictions. Through the TRCHR Computational Biomedicine program, we address all three questions. This is a picture of St. Thomas Hospital's museum. It's in London. It's a very creepy museum where you can see pictures of toe amputation in the Victorian era. I went there last year, actually no, 2 years ago by now. And there I found this. This is a copy of the medical record, the date 1883. Now, the shocking thing about this is that when you compare the way that the medical record is organized then versus the way medical records are organized today, there's been no evolution whatsoever. The patient name and patient numbers at the top of the page with the date of admission and the ward, diagnosis, outcome, name of treating physicians, history and symptoms, and examination and recommendation. Now, I know what you're saying. Well, come on, Cedric, we have computers now. We don't use a big black ledger book. But then when you think about what we're actually using right now, in modern EHR, free text is still king, data is still siloed, there's significant limits to information flow, restricted connectivity to outside world, poor data integration, and insufficient analytics capabilities. I would argue this is not much different than the big black ledger from 1883. Scary enough, when I started my position as director of CBDMC, we actually did an inventory of only the cardiac EMR across the U of T system. And this is what we found. We found 70 isolated data silos, 20 electronic health record platforms, 6 hospital and 4 legal entities, 3 government agencies who are dead set on not talking to each other, data loss from thousands of unconnected devices, large amount of data entry duplication, the majority of data stored in non-retrievable format. And in the words of one physician living through that, data that is so inaccessible is effectively lost. So the first challenge is to actually clean this up. And unfortunately, the solution here cannot come from existing hospital IT. And that's because hospital IT infrastructure is there to meet the legal requirements for the delivery of care, not necessarily to push the technology and innovation agenda forward. So we need to move from the healthcare data paradigm to a data-driven strategy. Right now, the healthcare data, in current healthcare data, the data stays where it's generated. It's manually copied and duplicated multiple times. It's not used for optimization, and it's not readily available to users. What we want is data to be generated only once in the system, used throughout to optimize process and keep the users informed. Now, the first thing that this requires is actually a change to how data collection is being done, because it all starts with data. You need a solid data strategy that does not rely on paper form or free text. This scary 6-page thing is an ICU flow sheet from UHN. It's put in the chart when the patient arrives in the ICU, and every day the nurse writes down their observations day after day, and it ends up being a large, scary piece of paper that gets scanned, transformed as a PDF, put in the EMR, and forgotten forever. You can't retrieve any data from that. And even more shocking, at the end of the shift, all the data that was used to generate that flow sheet gets deleted from all of the machines because the machines have no integrated storage system. The other major problem with the weighted clinical data are dictations. So dictations are free text of the impressions of the physician and a summary of what happened either in a procedure, in a clinic visit, or during an hospital admission. Those are completely unstructured data. And regardless of what people are saying, and by people I mean startup company, natural language processing of these data is still not possible to generate actual structured data in a valid way. So what we've done at PMCC is we've actually recognized that there would be some limitation to the amount of data available, but that there's still some data available in the system. So this is our data integration plan for participation in the National Cardiovascular Data Registry. So to participate in the National Cardiovascular Data Registry, NCDR, for every CAT procedures that are performed, we need to submit 525 variables. This is sent to Duke University Research Institute, where we get benchmarked against thousands of hospitals in the United States and millions of procedures. Now, the problem is that generating 525 variables on upward of 5,000 procedures a year is exceedingly time-consuming and very costly. The Cleveland Clinic, which has a patient volume about equivalent, has 28 full-time people working on this. We obviously can't do that. So what we did is we actually went through every single potential data sources that was generating structured data, harvested absolutely everything we could from those, and that actually required working with UHN Digital to change some of these sources so that the data collected is collected in a way that's compatible to NCDR. And then use the Digital Cardiovascular Health Platform, which is the data integration platform we are building right now that I'll talk about in a minute, to integrate the data from all of these different sources. Out of 525 required variables, we can integrate 425 from the medical record. That's 81% of the total. And then that makes participation a lot more manageable because then we can employ people to just fill in the gap rather than recollect everything. But this shows you how important it is to have a proper data collection strategy from the beginning. And that often involves changing the source clinical system, so what physicians are actually interacting with. Once that's done, you need to put data, once you have your data collection strategies, you need to put all the data in one place so it can be consumed. This is our picture of a data lake, which actually is Kate's doing. Kate is very talented to do that kind of thing. But the principle of the data lake is that you take disparate sources of information, you put them all in the same place in a common data language, and you do that by connecting all of the ancillary lakes to the main data lake, changing the information as needed, cleaning the information as needed, and then it can actually be used. Realistically, this is what it looks like, this big scary thing. So one of the important things, and that was the first thing I mentioned, the first problem that we have in making individualized medicine a reality is that we need a lot more data than the system is actually able to handle. And unfortunately, that really means that we are going to need a separate system to handle data integration and computational jobs that are not being handled directly through the EMR. So it starts with a platform brain that lives on a high-performance computing cloud. And it's associated with data ingestion tool. Now, these are, I call data ingestion tentacles. They're basically pieces of software, sync point, file shares, data extraction APIs that we can put in the source system, harvest the data in whatever format it is, and then change that data so it can actually get into the data lake. And that's a very important thing and something we learned very early on. It has very low acceptability to go around to UHM Digital or to IT groups, to physicians and say, well, we are actually going to change your entire workflow and you're going to get all of these new software. We're dealing here with a lot of legacy software, a lot of things that were written in the 1990s. Remember Windows 3.1? A lot of Excel spreadsheet, a lot of things like that. And there's some things that you can actually change for the better and readily integrate them, but there's others that you can't actually touch. You're stuck with that, and it's not something that you're going to be able to do anything about. So here, we're using a number of strategies to get all of these sources of data in. This is associated with a platform memory and an analytics engine. We then created a security and privacy layer around the platform that ensure data scrubbing, data encryption, and parsing, and that will ensure data security, enforce data governance, and protect patient privacy. Once this is in place, the data can then be used by intelligent clinical assistant and patient education tools. Now, this platform has been live since July right now. Out of the 60 data sources that we're planning on integrating over the life of this project, and that number actually keeps changing because we keep finding sources we didn't know existed. We're about halfway there. Right now, the platform has about 20 million data points, and we get 300,000 new data points every day in there, and keeps growing and growing and growing. Now, putting all of the data in one place where it can get access is one piece of the puzzle. The rest of the puzzle is making sure that that data is accessible. So we're creating an infrastructure, and that's something we're going to do over the next 12 to 18 months, where researchers, clinician, administrator will be able to make requests that will go through an approval process, which is going to be integrated with the REB approval. That's going to generate queries to the data lake and data release either back to the PI or to an analytics group. And then the result of these analyses being sent back to the PI. So in addition to putting all of the data in one place, we're actually also creating this suite of software that we're going to need for people that are not us to actually interact with the data platform and access that data. And that's also very important. we're removing one bottleneck at the beginning, that is bring all the data together. We don't want to replace that by another bottleneck at the other end. So in this case, we're dealing with both data ingress and data egress. And really the goal here is to maximize access and utilization of the data by taking out barriers, always with the perspective of respecting patient privacy and protecting data security. The last big part that we need in this data integration and analytics framework is the groups that are actually going to do the analysis. And that's often the part that is missed. At PMCC, we're using the infrastructure, so that means the data ingestion tools and the data store. We have a dedicated group that does nothing but data management, processing, and integration. And then that data will get released to one of 4 teams that each have their own area of specialization: biostatistics team, a data science and computational biomedicine team, a bioinformatics team, and the still to be created PMCC AI team, the artificial intelligence team. That data, those analytics models are then using our analytics delivery engines that get data and analytics out of the DCHP and back into the clinical systems. And that can be consumed by decision support tools, patient education, and software, and for hospital management. So that's the first part. The first part is the hospital IT infrastructure. Now we're going to talk about analytics. This is the visa fraud detection platform. It's based on artificial intelligence. It uses 500 unique attributes to determine in less than 1 millisecond anywhere in the world if a transaction is fraudulent or not. It does that 30,000 times per second. That's 150 million times a year with 99.94% accuracy. You look at this, and then you realize that we routinely get papers published with predictive models and that have accuracy in the low 70s. And we're actually pretty happy with that, because that actually can still get you in a top-tier journal. And I'm asking, well, what's wrong here? Why is it that Visa can have this model that is infinitely more accurate than anything that we've ever published? And in short, there's 2 big reasons. They have a lot of data, and they've invested heavily into using that data over time. They've done that a long time ago, but they've also embraced analytics methods that deal with complex systems as opposed to a reductionist approach. And part of that is machine learning. Now, machine learning is not new. This is a paper that was published in 1959 in the IBM Journal of Research. It's the first example of a computer program beating an average human player at checkers. So when we think right now about everybody going on the machine learning, artificial intelligence bandwagon, that's the first question we have to ask is, well, this actually has been around for 50 years. Yeah, 50 years, almost 60. Why is it that all of a sudden we're just rediscovering it? And why has it been largely ignored by medicine for nearly 50 years? The first thing that we have to consider is the elements of statistical thinking versus machine learning. So statistics is there to assess the relationship between variables in the form of a mathematical equation. It includes the generation of confidence intervals. It's about quantifying uncertainty. And it predicts outcomes by finding relationship between variables. At the opposite, machine learning learns from data without relying on use. That's actually one of its main key strengths. It can use undescribed patterns in data to generate prediction. It tries to select the most likely outcome or class. It's about achieving the best prediction, not necessarily telling you how confident it is and how probable that decision is, or that prediction is. And it predicts outcomes by recognizing patterns and through previous experience. Now think about what we're doing in medicine. In medicine, most statistics are going to be most suitable for situations with high uncertainty. That means management plan, treatment response, prognosis, for example. And that's what historically has been medical research. And when you look at what statistical thinking does, this is the kind of question you're asking. While machine learning and medicine will be most suitable for very deterministic high dimensionality and high frequency data. That means imaging, diagnostic, physiological monitoring, for example. And the thing that has changed in the last few years is that that data is now available and the compute power to analyze that data is available. So we have to be careful here. While it is very likely that machine learning will have more and more of an impact in predictive analytics and healthcare, it will have an impact mostly in those areas.
I can ask a question. Maybe the biostatisticians in the room are kind of squirming a little bit because I don't think that's quite an accurate description. I mean, machine learning, there's somewhat of a buzzword thing going on here, but everybody uses statistician uses a machine. First of all, we don't do things without machines. And we do more than just generating confidence intervals. Prediction is a key part of statistics and biostatistics, as you probably know.
Yes.
So there's an awful, I mean, I think that there's a lot of overlap between these two areas. And I think probably the biggest distinction is maybe the first line. And that, one of them, I guess you think of neural networks and that sort of thing, which doesn't prescribe any particular things, but look for and discovers relationships between inputs and outputs. We still specify the inputs. You don't specify the relationships necessarily. Whereas in the statistics classically, you actually specify what kind of format there are, but there's a lot of flexible models now, as you probably know as well, that don't really, they're not just simple linear relationships between inputs and outputs.
And I'll get to that in a second.
Yeah.
And so one example of this here is that one example of this dichotomy is that in studies that are coming out right now using machine learning that shows very high model accuracy, they tend to actually end up in that imaging, high dimensional, high dimensional and high frequency data. And this is an example of a study that showed a model accuracy of 97%. But then whenever machine learning has been used and with more classic EHR data, model accuracy is much, much lower. And this is often because the EHR data is often messy data. And a lot of models have been are being created without a rigorous evaluation process, an evaluation that is done outside of clinical context. And there's been many pilot projects, but few real success stories. Now, as Dr. Tomlinson was saying, there is a lot of overlap between the two, and the future is most likely going to be in ensemble models. So ensemble models are models that include more than one algorithm that can either be statistical or AI-based, and allows the combination of multiple models to generate prediction. In this perspective, AI-based model can be used for feature extraction, but prediction stays primarily in the realm of statistical model. And that, I think, is where the true innovation is going to be. So now I'm going to talk about a few examples of studies that we've performed in the last few months that have actually used either novel method or novel approach to actually look at data a little bit differently than we've had done previously. So this is a study that was presented at the International Kawasaki Disease Symposium in Japan in June, and it's on the epidemiologic evidence of spatiotemporal clustering of Kawasaki disease and coronary aneurysm in Canada. Now, so we've been monitoring Kawasaki disease. It's a pediatric illness that has very severe consequence for children for years, and we've been publishing a version of this paper every 3 or 4 years since the mid-90s. It's always the same. It's incidence per region and province over time, seasonal patterns, the proportion of patients with with coronary aneurysms and negative outcomes, and then the incidence per age. But through linkage of data, we actually were able to link the data from CHI, so the data from all cases of Kawasaki disease in Canada, with weather data, and actually were able to find a link between the disease, between the epidemiological distribution of Kawasaki disease in Canada and weather patterns and pollen. We also use a spatial-temporal clustering analysis to identify a cluster of very high and very low incidence throughout Canada. And we were fortunate enough that one of those clusters was actually in Toronto in the mid-2000s. So by actually identifying this cluster, we were actually able to look at the characteristics of the patients within this cluster versus other clusters, versus different types of control, and actually show that the patients in this cluster had a slightly higher rate of conjunctivitis, oral mucosa change, and antibiotic treatment, which suggested that there might have been a specific infection that was associated with that specific cluster. By looking at the data a little bit differently, it's the same data that we've used in both papers, but by looking at it a little bit differently, we actually were able to generate significant advances in our understanding of the etiology of Kawasaki disease. We also look at new methods to look at, very high dimensionality data, high frequency data. So this is a cardiopulmonary exercise test. It's a key prognostic factor for patients with heart failure, which involves two components. It involves a measurement of exercise capacity through a maximal exertion test, and a measurement of respiratory function through breath-by-breath analysis. Now, breath-by-breath analysis, it literally is 60 different factors being measured every time a patient breathes in and out. It's very highly dense data. And historically, most of that data has been summarized in a few key indicators. And out of these thousands of data sets, of data points that are being generated during an exercise test, physicians end up using only 4 or 5 for prognostication. So the question we've asked is, can we look at subtle variation in breath-by-breath data, which are ignored by conventional risk model, and see if we can improve the predictive ability of cardiopulmonary exercise testing? So we took data from 1,100 patients, classic heart failure patients, and assessed their outcome, progression to end-stage heart failure at 1 year. That's transplant, listing for mechanical support, or death. We then look at all the individual indicators on their own, and then a number of more complex models that use stage data and the full breath-by-breath data, and actually showed that using all the data generated, including the breath-by-breath through a neural net, allowed us to generate the best prediction in this group. So we've shown that by actually reducing the complexity of the data to make it more palatable for doctors, physicians, we actually ended up reducing the prognostic value of exercise tests. We concluded that paper, which just actually got published today in Circulation Heart Failure. We ended up that paper by saying that the simplification of high-resolution information is unnecessary when appropriate analytic strategy are used, and it may limit the performance of predictive models derived from prognostic tests. We can also use unsupervised clustering to understand more. To better understand the some of the disease we're working with. This is again Kawasaki disease. In Kawasaki disease, one of the main problems is resistance to IVIG. Resistance to IVIG is highly associated with coronary artery abnormalities. These children who are resistant can have rates of coronary artery abnormalities up to 3 or 4 times higher than children who respond to the first version. And one of the big problems with resistance to IVIG is that despite tens of papers and tens of risk models that have been created to try to predict who will be resistant and who won't, we actually found very low accuracy across all models. And these models, even though are performing quite poorly, have never really been used, are being used in routine clinical system right now. Now, what we did is we used a self-organizing map here to try to cluster patients based on age at diagnosis, C-reactive protein, confirmed infection, total dose of IVIG, brand of IVIG, number of days of fever, maximum temperature, and fever profile during the initial IVIG infusion. And what we actually found is that we were looking at that problem in the wrong way. We're not actually trying to predict response versus not response. We're trying to predict response versus 2 different types of non-response. And that was a big revelation. That was also presented at the International Kawasaki Disease Symposium, but also at the AI Med conference last year. Because for the first time, we actually showed that really what we were predicting here were 3 separate phenotypes as opposed to response versus not response. We found that when, obviously the responders were easily identified, but one group of patients were most likely having infection and smaller doses of IVIG, while the other group of patients had a number of inflammatory-related markers that made their own disease much more difficult to treat. So we are now working on a predictive model that will predict in the non-resistant patient which of the 2 phenotypes the patient is, and then we'll target treatment specifically based on that. Now, this is a slide I've shown a lot lately, and this is directly from my PhD, and it kind of shows how the process of looking for complex system and trying to understand complex system works over time, and that's changed recently. So the goal of my PhD was to predict in a cohort of 400 patients who would get postoperative thrombosis. That's fairly easy. It's fairly straightforward. We looked at 493 predictors, which many predictors, for those of you who have worked on studies where there's a high physiological component, I'm sure you've noticed many of the predictors are highly correlated with each other. And basically, the main analytics approach is to first create a theoretical framework of the situation you're trying to understand, and then look at a lot of bivariate associations, try to understand how things move, and then create a basically theoretical framework of what you found. And this showed the clinicians understand very well, oh, well, okay, this kind of makes sense, and it goes, it makes a lot of sense, and it's associated with what we think of clinically. But the problem with this theoretical framework is that it's a non-solvable framework. It cannot be used for predictions. So you end up with all of these models looking at a subset of the association and never really considering the whole system. And what we've done here is using clustering network analysis, we actually created a network of this, found the same general cluster and the same general organization of the data that we found using more of a theoretical framework based on these bivariate association. But the important thing is that this is actually solvable. you can actually solve this system and generate individual predictions in a way that we haven't been able to do before. So the last part that I'm going to discuss today is the implementation problem. So we discussed the data technology, the data integration technology, and how to actually remove the data ingress and data egress bottleneck. We discussed the fact that some of the analytics methods we're using could be improved by looking at the data a little bit differently and staying away from an overly reductionist approach. Now we're going to talk about the third challenge, and the third challenge is going to be to bring those predictions back to healthcare. Because a big problem right now, and a very consistent one, is that there's a lot of models that end up in a publication and then die on a laptop somewhere and are actually never used in clinical care. And this actually was shown by this study. This is a systematic review done by Wessler a few years ago of 800 models, just cardiovascular prediction models that were all published. So this is all 800 papers in PubMed, and showed that out of these 800 models that were developed, only 10% of them were properly validated. Less than 1% had an assessment of their impact on patient outcome, and then less than 0.1% actually were used in clinical settings. The 1% is the 0.1% is one model, the Seattle heart failure model, which is routinely used. But when you look at this, you can understand that there is a clear implementation problem. Now, the first part of the implementation problem is that models, even regardless of how they're done, are a bit scary when you actually don't understand how they've been made. That's the black box problem, and it's more important in machine learning than in other methods, but it's there everywhere. And the machine learning black box paradigm basically tells us that models often have an unexplainable decision process, and that leads to limited trust from physicians. There's a few potential solutions, including the use of transparent machine learning methods, the reverse engineering of the thinking process, and behavioral decision simulation. And that's a very important and it's a very important consideration for the future. For the longest period of time, people have focused on transparent model where you can actually understand how the model comes to a prediction and decision. But things like deep learning will not allow that. Now, deep learning is very powerful, so you don't want to give this up, but you actually need to find ways of explaining the decision process and the rationale behind decision. And the reverse engineering of thinking process, and especially the behavioral decision simulation, so providing a lot of data to a model and then correlating the predictions versus the input is actually going to actually allows you to say a lot more about what why the model predicts things it predicts. In that regard, one of the important things about implementation, and that has been definitely a problem with the Seattle heart failure model, is that models get stale very quickly. That means that by the time a model is generated, it's often generated on retrospective data, so the patient population has already changed, the clinical setting around it has already changed. So model accuracy really, in a proper implementation setting, should obviously provide useful information and be clinically relevant, not be overfitted, be validated both internally and externally, be tested and evaluated using proper epidemiological methods, be revalidated when implementation conditions are different than the development condition, be properly evaluated for effect on outcome, and be continuously revised and have their performance monitored. It's also really important to consider in the implementation human factor consideration. That is how those models are going to be used by the physician. It's more and more evident now that just putting in number on a piece of paper is not sufficient. Things like alert fatigue, visual cognition, audible and visual noise, training, workflow efficiency, consistency, interruption and distractions are all things that affect whether a model is going to get translated into clinical care or not. And that's a big area of future research. But more importantly than that, I think, is we have very little information right now on how predictive analytics can affect a physician's perception of the patient, prognostication, and intended management. And we have no data on how physicians react to and handle potentially wrong predictions. So we did a simulation study where we actually took the data from 127 fetuses that were assessed at sick kids for potential left heart disease. That goes from mild heart disease, where the kid is going to be completely healthy at birth, all the way to severe apoplastic left heart syndrome, where the child will require multiple surgeries while before their first birthday. And what we did is we generated 1,200 standardized case report forms with no predictive analytics, some with accurate predictions, some with overly optimistic predictions, some with overly pessimistic predictions. And then we asked 7 pediatric cardiologists who didn't know what we were up to answer 4 questions about the child. What do you think the clinical outcome is going to be? Is this child going to be cardiac compromised from a cardiac function point of view at birth? And where should the postnatal care of this child be carried out? Now, what we found, and that was not surprising at all, is that physicians are not particularly good at predicting outcomes. They underestimated the probability of negative outcomes significantly. And even when giving them prediction, it only marginally improved their overall accuracy. But what we especially found is that physicians were also unable to recognize incorrect prediction, and this negatively affected their decision process. So particularly when physicians were presented with overly negative predictions, it actually it provided confirmation bias, and they started seeing and recommending treatment for these children that were far more aggressive than what the clinical case without the prediction would have warranted. Now, this is actually data that nobody has seen before because we collected it on Monday. So Monday, I was at a workshop at the Canadian Cardiovascular Congress, and as part of a panel, and we used the audience response system to actually see how physicians felt about machine learning in general, but really about predictions more than anything else. And so I'm going to share a little bit of that, and then you'll understand, I hope, why the implementation gap is so important. So the first question we asked is, how much do you know about artificial intelligence? And 62% of physicians said, well, actually not more than the basis. 32% said broad concept, and only 5% said that they were quite knowledgeable.
Could anybody say no, nothing? Was that one of the options?
Yes, that was one of the options. No one chose that. No. But that's, yeah. Nobody said no to that. Now, this one is interesting. Do you think that artificial intelligence will ever have a substantial impact in clinical cardiology? Nobody says not really, just the fact that will eventually go away. 27% said likely, but not for tomorrow. And 73% actually thought that it will have a substantial impact. The majority also agree with this statement that says that artificial intelligence will be necessary for predictive models to be created in cardiology. And this highlights a very strong dichotomy here. They don't know much about it, but everybody is convinced that this is happening and it's absolutely needed. despite actually this was a debate making, I think, a convincing argument that it actually probably wasn't absolutely needed. But apparently I lost that debate, obviously. This is another interesting one. How would you use clinical prediction provided by clinical decision support system in your clinical practice? Nobody said they would ignore it. 5% said they'll look at it, but look at this. 73% said they'll consider it, but it's just another data point. And only 22% actually said that they would likely rely on it on to a substantial degree. Yet what we've shown in the simulation study is that actually they do rely on it to a substantial degree. Unsurprisingly here, 2/3 of people in the audience didn't think that the IT and data infrastructure system available in hospitals and the healthcare system in general were ready for any form of AI. And here, when asked about how much they would trust decision to perform and make clinical task and decision, the majority of people said that they would be okay with AI algorithm making low complexity clinical task and decision, and only if they can override it. Only a very small portion of the people responding in the audience actually would say that they would let an artificial intelligence system perform complex tasks even after it's been completely validated, Now this one is the scariest. Automatic artificial intelligence is a realistic and desirable goal for medicine. Automatic intelligence, AI, is a form of AI where the AI takes decisions without human supervision and implement those. That's the worst form of science fiction AI. Yet 80% of the physicians in the audience said, yeah, we're good with that. So what this shows is that, so there's a lot of implementation gap, and there's definitely big implementation problem. And a big part of that gap is going to be education of physicians, because right now what they say that they believe and they do is different than what they are actually believing and doing. So where do we go from there? Well, the ultimate goal is to continue bridging the gap between complex system and the healthcare system. This requires continuing developing and extending the big data infrastructure in clinical setting, developing new ways of creating more accurate predictive models, and study out the integration of predictive analytics and clinical care. For that, we're going to continue using our own approach, which is industry partnership, technology repurposing, aggressive development cycle, and startup management strategies. It really is a new type of collaboration where clinical integration, computer science, and analytics come together to actually try to harvest the data, generate better prediction, and then deliver these predictions in a way that physicians are going to be able to use. Thank you very much. I think we have a few minutes for questions.
Absolutely. Any questions in the audience?
Yes.
Murray, please go ahead.
Really smart. Thank you for that. I mean, I'm one of those people who is like with George, who knows zero about artificial intelligence, so take that on board. But I guess when I hear talks like this, it has the flavor of sort of solutions in search of a problem to some extent. I mean, that's probably overstating it a bit, but you have the data, you have methods of analyzing the data, and the challenge is that interface, as you've indicated in the last part of your talk, with working with the people who ultimately will be making decisions and who bear the responsibility for those decisions. And I just wonder if there is if you thought of a role for people who have a background in decision science. Like, you're obviously focusing on the clinicians, but there's a whole group of people that actually study decision making. Decision scientists, biostatisticians do this to some extent, epidemiologists do this to some extent, have a kind of a critical view of decision-making in medicine, and whether what might be useful to also integrate those kinds of people in thinking about what kind of questions can be posed to the data and the models, rather than thinking about how to apply the data that you've got.
And that's absolutely correct. One of the big problem right now is that the majority of people focus on, we have all of this data, what can we do with it, as opposed to actually this is the problem, how do we find a solution to it? So I'm only one half of the computational biomedicine program. The other half is Heather Ross, who's a clinician. And we actually go with let them ask the question, and then we'll work with the different groups to have solutions. So in my group, we have technology experts who do more of the infrastructure build-up and things like that. My analytics group actually has both biostatisticians and data scientists that approach problems differently and move problems based on, for the type of question you're asking, this is the best solution. And then the implementation is more difficult right now. That's the part where there's still gaps. The human factor team at THETA is very good in that, but they're like a lot of us, there's a lot more demand for their time than they have capacity. But those are going to be the people who are going to be able to work in that. But I agree with you.
That's just a suggestion, because I think all of those people are great, and the human factors people, that's really good. I do think, though, getting input from some epi types and from some shared decision-making, decision scientist types might also be a useful supplement to these very rich resources you have.
We have one question online.
Yes.
So Dr. Valeria Rack is asking, how do you plan to educate healthcare providers on machine learning and AI? Because based on the poll, that's highly needed.
Yes. So as I mentioned, that data was Monday morning. And although I had suspected that, I didn't think it would be that bad. At this point, that's something that will have to be done. But the how, I have no idea yet. I think this type of forum is good, but then so some more formal ways of training is probably going to be a potential solution. We'll have to think about this, right? It's the same thing then in the 90s when physicians started learning a lot more about biostatistics. It took a long time to actually get everybody on board, and I think we'll have to do the same effort with machine learning.
Yeah, it was a great talk. Really, really interesting. I'm wondering if you've been thinking, because you've obviously identified how siloed data is in medicine, if you've been thinking about how to bring healthcare together on this. This is great work within cardiovascular medicine. I guess, my thinking is that there's a bit of a risk here in creating another set of silos. I'm sure you're very sensitive to that, and I'm wondering if you're thinking of a way to bring all the data together. These folks are, anyway, I have a couple of other questions, but I'll leave you with that one.
So that one is really important. So when we started this, obviously we went to the institution, to UHN, and said, we want to do this. And then a whole bunch of alarm bells came out. So we actually said, well, we're going to do this along with UHN Digital, and we're going to pilot test it in cardiac, but then it's going to be extended to the institution. And that's the goal. We're close to the point where the infrastructure we're building is actually going to be turned over to UHN, and it's not going to be a cardiac project anymore. I think that's, and as kind of a roadmap for radical innovation, that's a good one. Having a pilot project that's on a smaller scale, because this looks like it worked and we just kind of started and did it, but it's been 3 years of nightmare and things not working out and having to go back to steering committee and say, I need under 6 months to deliver this and that. This is not, until very recently, this was not ready for wide-scale deployment, but that was always part of the where we're going. It will be deployed.
One other quick question. So I heard another talk earlier this week, and it sort of relates to sensitive dependence on initial conditions.
Yeah.
So there's those wonderful slides of the horse, and then you change 1 pixel in the whole picture, and the machine learning thinks it's a frog.
Yes.
So I think we have some of those issues in medicine where, because of inequities in the society, there are some people who don't access the health system.
Yes.
And so their data is not there. And so these models, this was the speaker who was saying this, I thought it was very interesting, there's a risk of actually increasing the inequities in care if this isn't recognized or somehow managed.
That's actually, that's a great point. There is a risk, and there's actually a lot of examples of model actually being trained to replicate human bias or societal bias and inequities, and large-scale implementation and automation of that just made things a lot worse. It's something that absolutely needs to be considered. There's a great book called Weapons of Mass Destruction, which it's a beautiful read on specifically the danger of imparting to predictive models the bias and inequity of the world we live in, because the training data that we're using, it's an excellent point, and that's not something that has been solved. It's an ongoing problem that you have to consider when you consider whether a model makes sense or not to be used.
Okay, we probably have time for 1 or 2 more questions. Anybody else in the audience? Go ahead.
In these like AI models, there's a lot of like, okay, I need accuracy. I need 70. I've got 80% accuracy. But in a lot of cases, especially when you're helping clinical decision making, you don't necessarily need to know whether it's a yes or a no.
Yes.
You need to know the yeses and the nos, but you could also very easily have a maybe that tries to capture the people who get incorrectly specified. Have you put that in your models, or is that something you've seen very much of?
So that's actually, so in the slide where I'm talking about what makes a good model, I kind of allude to the fact that one of the big problems right now with all of the, let's call them the hardcore machine learning papers that seep into the clinical world right now, is that they're evaluated based on computer science, not on medicine. And one of the things that I've actually been very, very interested in is actually is on the evaluation of predictive models that is much more closely related to what you would expect of any predictive model going into medicine. That includes things like uncertainty in between categories, but then also having a proper assessment of sensitivity, specificity, things like that, and not just focusing on raw accuracy. That's something that has been very pernicious in the last few years, and that is very much a problem. And I think that one of the good things with physicians getting more and more interested in that is that they're more and more willing to actually evaluate these models the same way they evaluate everything else, as opposed to just glossing over the paper and say, this looks cool. And then it has a 97% accuracy.
I have one. Oh, did you have a question as well? Okay, sorry. So I have a question, and it kind of relates to actually collecting data, and particularly from patients who, in today's world, we hear a lot in the news about how, large collections of data unfortunately being mismanaged by certain companies. Facebook, for example, comes to mind, right? So I feel that, just the, heightened awareness of that is not really helping us as researchers to win over patients' favor in terms of actually collecting their data, which is really like almost like a donation, if you will, of information that we're going to be using for making these decisions. You mentioned as well that one of the concerns or one of the issues with machine learning is the black box issue, and you talked about how there might be some techniques that could be used to overcome that. And I'm wondering if perhaps like those same techniques or the outcomes of some of those could actually be used to help inform patients to reduce anxiety about providing data, especially for a study that is looking to use some of these machine learning techniques.
Okay, so those are a little bit two questions. Let's first the consent, the consent of the patient themselves, and the concern about privacy. That's very important. So in parallel to this, PMCC is, as part of their strategic initiative, approach almost every patient, and soon enough it's going to be every patient for participation in the biobank. That also includes a detailed questionnaire about what they consent to from a data perspective, and that is part of the data structure, is really having patient consent. That's done by coordinators that can actually answer patients' questions and do some education. Now, on the model side of it, patients don't really care where the prediction comes from. They just see a number. And right now we're actually being, at least for what we do, we're being very careful not to actually let people see these predictions because they haven't been properly evaluated. I think that in the same way that medication are put through a rigorous trial process where all of the aspects of safety and efficacy is assessed, eventually algorithm will have to go through the same thing, and that's the way to actually get patient buy-in to using those. Unfortunately, that's something that's not done because it's still in a gray area. There's a lot of very big healthcare systems, particularly in the United States, who have very large implementation of EPIC that seep in predictive model and inpatient care without proper evaluation, and I do think that's a dangerous practice. But I think the goal, in the same way that patients get to trust medicine, even though medicine can have side effects, even though there's risk to them, I think that's kind of the same. It's the same approach with algorithm, especially those that make more than scheduling decisions.
That's a great idea. Good point. Okay, well, I think that might be it then. Questions. Thank you very much.